Peptic ulcer diseases. These are defects in the gastric or duodenal mucosa that extends through the muscularis mucosa, which produces burning epigastric pain that is exacerbated by fasting and improved with meals. The mucosal defense system can be looked as a three-level barrier composed of epithelial, preepithelial, and subepithelial elements. The first line of defense is a mucous bicarbonate phospholipid layer, which serve as a physical and chemical barrier to multiple molecules, including hydrogen ions. The surface epithelial is the next and provides mucus production. Epithelial cell ionic transporters that maintain intracellular pH and bicarbonate production and intracellular tight junctions. Subepithelial defense system, also a repair system. It is a microvascular system within the gastric submucosal layer. It is the key component that provides bicarbonate, which neutralizes the acid generated by the parietal cell, and also provide an adequate supply of micronutrients and oxygen while removing toxic metabolic products. Hydrochloric acid and pepsinogen are the two principal gastric secretory products capable of inducing mucosal injury. Gastric acid and pepsinogen play a physiologic role in protein digestion, absorption of iron and other elements, and the killing of ingested bacteria. Acid secretion comes in basal and stimulated conditions. Basal acid production occurs in a circadian pattern, with highest level occurring during the night and lowest level during the morning hours. The reason why patients with acid-related diseases usually wakes up in the early hours due to pain. Cholinergic input via the vagus nerve and histaminergic input from local gastric sources are the principal contributors to basal acid secretion. Peptic ulcer disease encompasses both gastric and duodenal ulcers. Ulcers are defined as breaks in the mucosal surface of more than 5 mm in size, with depth to the submucosa. Duodenal ulcer and gastric ulcers share many common features in terms of pathogenesis, diagnosis, and treatment, but several factors distinguish them from one another. Duodenal ulcers, it occurs in up to 15% of the Western population, and the incidence of DUs are declining. The reason for the reduction in the frequency of DUs is likely related to the decreasing frequency of H. pylori. Before the discovery of H. pylori, the natural history of DU was typified by frequent recurrence after the initial therapy. While gastric ulcers occur later in life than duodenal lesions, more than one-half of the gastric ulcers are seen in males. Duodenal ulcers are usually located in the first portion of the duodenum, more than 95% of cases. It can be as small as 1 centimeter in diameter and can reach up to bigger ulcers up to 6 centimeter, and we call it giant ulcers. Ulcers are sharply demarcated. Malignant duodenal ulcers are extremely rare. In gastric ulcer, GUs can represent a malignancy and should be biopsied. Usually benign when it is located distal to the junction between the antrum and the acid secretory mucosa. Benign ulcers are rare in the gastric fundus. The most common cause of duodenal ulcer are H. pylori and intake of nonsteroidal anti-inflammatory drugs. It is also associated with in an increase in average basal and nocturnal gastric acid secretion. Accelerated gastric emptying of liquids are noted among these patients, and bicarbonate secretions are usually decreased in the duodenal bulb. While in gastric ulcers, the majority of the cause are still the same: H. pylori or NSAID-induced mucosal damage. The gastric acid output, which are the basal and the stimulated, are usually normal or decreased. The gastric ulcers are classified based on their location. We have type 1 up to type 4, wherein type 1 usually located in the gastric body associated with low gastric acid production, while type 2 is located in the antrum, gastric acid from low to normal. Type 3 is within 3 cm of the pylorus, accompanied by duodenal ulcers, normal or high gastric acid production, and type 4, located in the cardia, low gastric acid production. Helicobacter pylori and the acid peptic disorder. Gastric infection with the bacterium H. pylori accounts for the majority of peptic ulcer disease. This organism also plays a role in the development of gastric mucosa-associated lymphoid tissue or MALT lymphoma and gastric adenocarcinoma. It is still not clear how this organism, which resides in the stomach, causes ulceration in the duodenum. H. pylori eradication may lead to decrease in gastric cancer in high-risk population. It is seen in as much as 80% of the population in the developing countries, and they may be infected even by the age of 20. As compared to industrialized countries, they can have only up to 50%. The factors that predispose to H. pylori colonization are poor socioeconomic status and less education. The transmission of H. pylori occurs from person to person, and it is transmitted through oral to oral or fecal-oral route. H. pylori is associated with chronic active gastritis, but only up to 15% will develop frank peptic ulceration. The relationship of H. pylori to gastric ulcer is about up to 60%, and a little bit higher with duodenal ulcer reaching up to 70%. NSAID-induced peptic diseases. While NSAID is the most commonly used medication, thus the side effects and complications are considered to be the most common drug-related toxicities in the US and in most parts of the world. The spectrum of manifestation ranges from a very common nausea and dyspepsia, which occurs up to 60% of patients, or to peptic ulceration complicated by bleeding or perforation. It is very important to identify who are the people at risk because of the lack of warning signs, and there is no dose that is safe. And the risk factors are multiple, including advanced age, history of ulcer, concomitant use of steroids, high-dose NSAID intake or multiple NSAID intake, and concomitant use of anticoagulants, clopidogrel, and serious or multi-system diseases. The prostaglandins play a critical role in maintaining gastroduodenal mucosal integrity and repair. It therefore follows that interruption of prostaglandin synthesis can impair mucosal defense and repair, thus facilitating mucosal injury. Injury to the mucosa can also occur as a result of topical encounter with NSAIDs, leading to increase Epithelial surface permeability. Aspirin and many NSAIDs are weak acids that remain in non-ionized lipophilic form when found within the acid environment of the stomach. Under this condition, NSAIDs migrate across the lipid membranes of epithelial cells, leading to cell injury once trapped intracellularly in the ionized form. The pain pattern in gastric ulcer are usually precipitated by food, and the most common manifestation is epigastric tenderness, and the pain may be found to the right of the midline in up to 20% of cases. What are the complications? We have the gastrointestinal bleeding, which is the most common. 15% of the patients and often more than 60 years of age. The mortality rate is up to 10%. Perforation is the second most common in as many as 7% of the peptic ulcer disease patients, and the mortality goes higher, up to 20%. Penetration is defined as the ulcer bed that tunnels into an adjacent organs. Gastric outlet obstruction. This is the least common, and they can present in two forms, the relative obstruction and a fixed one. Relative obstruction is due to the edema in the peripyloric region and often resolves with ulcer healing. And fixed obstruction is brought about by the scar formation after the ulcer has healed, usually in the peripyloric area, which is the narrowest portion of the stomach, distal stomach. Diagnostic evaluation. Barium studies of the proximal GI tract are rarely used as a first test for documenting an ulcer. The sensitivity of a single contrast barium meal for detecting DU is as high as 80%. With double contrast, it will be as high as 90%. Sensitivity for detection is decreased in small ulcers less than 0.5 cm with the presence of previous scarring, or in post-operative patients. Endoscopy provides the most sensitive and specific approach. In addition to permitting direct visualization of the mucosa, endoscopy facilitates photographic documentation of a mucosal defect and tissue biopsy to rule out malignancy or H. pylori. They also provide a very useful or helpful strategy in identifying smaller lesions and evaluation of atypical radiographic abnormalities. For the treatment, basically we are going on the premise of eradication of the infection if the causative is H. pylori, and therapy or prevention of NSAID-induced disease. We have different kinds of drugs. We have the aluminum base or the magnesium base. But since this drug produce a side effect, they are better combined to counter the effect of the other. That's why we have aluminum hydroxide and magnesium hydroxide. And we have others such as calcium carbonate and sodium bicarbonate. We have the H2 receptor antagonist, exemplified by cimetidine, ranitidine, and so on. They inhibit basal and simulated acid secretion. And for active ulcers, they can be given up to 6 weeks in combination with antibiotics to eradicate H. pylori infection. And we have the proton pump inhibitors. We have the first generation omeprazoles and the later generations aripiprazole and pantoprazole. They inhibit all phases of gastric acid secretion. Their onset of action is rapid and can reach up to 6 hours, and duration of inhibition up to 96 hours. We have cytoprotective agents. We have sucralfate. It becomes a viscous space within the stomach and duodenum and serve as a physicochemical barrier. It enhances the prostaglandin synthesis and stimulates mucus and bicarbonate secretion. Other agents are colloidal bismuth subcitrate and bismuth subsalicylate. They have anti-H. pylori activity and the mechanism of action is unclear. Prostaglandin analogs. Their role is in maintaining mucosal integrity and repair. Their action is through the enhancement of this mechanism. The most common toxicity is diarrhea. Other major toxicities include uterine bleeding and contractions. The therapy for H. pylori. Documented eradication of H. pylori in patients with peptic ulcer disease is associated with dramatic decrease in ulcer recurrence to 10 to 20% compared to patients in which organism is not eliminated. It is seen in 59% in patients with gastric ulcer and 67% in duodenal ulcer patients. The goal of therapy for NSAID-related gastric or duodenal injury is to treat the active ulcer and the primary prevention of future injury. We can use any of these acid inhibitory agents, such as H2 blockers, PPIs, also can be combined with antacids, but only PPI can heal gastric ulcer or duodenal ulcer, whether NSAIDs are discontinued. Surgical intervention in peptic ulcer disease can be viewed as being either elective for treatment of medically refractory disease or as an urgent or emergent for the treatment of an ulcer-related complications. The need for surgery has decreased substantially because of the more potent drugs and the more extensive use of endoscopic procedures. Bleeding is the most common and it occurs up to 25% of patients. Patients unresponsive or refractory to endoscopic intervention will require angiographic intervention or surgery. Other costs for surgical therapy are free peritoneal perforation, peptic ulcer that can also penetrate into adjacent organs, and patients who present with pyloric channel ulcer or DUs that can lead to gastric outlet obstruction, which is seen in up to 3% of the patients. Other related conditions. We have gastritis. It has been classified based on the time course, which is acute versus chronic, histologic features, and anatomic distribution or proposed pathogenetic mechanism. Acute gastritis. The most common cause of acute gastritis is infectious in nature, and it is associated with H. pylori-induced gastritis. It is manifested by a sudden onset of epigastric pain, nausea, and vomiting. Other organisms are implicated, such as streptococci, staphylococci, Haemophilus species, Proteus. Chronic gastritis, it is diagnosed histologically. Inflammatory cells infiltrate consisting of lymphocytes, plasma cells, and scanty neutrophilic involvement. The inflammation is characterized by patchy initially involving superficial and glandular portions of the gastric mucosa. It can progress to glandular destruction with atrophy and metaplasia. We have three phases of chronic gastritis characterized histologically by superficial gastritis, wherein the inflammation involves the mucosa and lamina propria. Atrophic gastritis deeper infiltrates with distortion and destruction of the glands. And gastric atrophy is the loss of glandular structures. The classification of chronic gastritis, we have type A and type B. Type A is body predominant form and it is autoimmune. Type B is antral predominant form and it is associated with H. pylori infection. The type A, there is antibodies to parietal cells, more than 90% of patients with pernicious anemia. The parietal cell containing gastric gland leads to achlorrhgia, and therefore the patient will have vitamin B12 deficiency producing megaloblastic anemia and neurologic dysfunction. While the type B, there is multifocal atrophic gastritis, gastric atrophy with subsequent metaplasia. It may lead to gastric adenocarcinoma, and it is associated with H. pylori and with a low-grade B-cell lymphoma or gastric malt lymphoma. For the treatment, we have to treat the associated conditions. For example, patients with pernicious anemia are given with parenteral vitamin B supplementation. And presence of H. pylori is not routinely recommended unless the patient presents with peptic ulcer disease or with low-grade malt lymphoma.